Welcome, everyone. Thank you for joining us today for our webinar entitled Addressing Alzheimer's in Tribal Communities. My name is Edie Yao. I am Senior Director of DEI Engagement with the Alzheimer's Association. I believe this is our third year now of doing this webinar, and very excited to be joined by our esteemed panelists. We've been partnering with Indian Health Service on this, and I'm looking forward to hearing from our speakers. So today, in celebration of National Native American Heritage Month, the Alzheimer's Association honors those who are facing dementia and those supporting their elders, relatives, communities, and tribal nations. Today's program is an opportunity to share information and resources while lifting up American Indian and Alaska Native voices to pursue health equity. And I can tell you, I've seen tremendous progress in the work that is occurring from my perspective, and from our partners' perspectives in really trying to provide more Alzheimer's and dementia resources to Native Indigenous communities everywhere. And so with that, I will introduce our panel. We have Michelle Archuleta, who is the Community Health Representative Program Lead from Indian Health Service. She is the National CHR Program Lead. And then we also have Susan Ducour. Dr. Ducour is an area nurse consultant, among many things, and she's been, I learned, working at Indian Health Service for, I believe, over 25 years. And she is the Indian Health Service California area office area nurse consultant, again, among many other things. And then we also have Dr. Kim Hartwig. She is a board-certified family physician, graduate of University of Washington School of Medicine. She serves on our Healthy Brain Initiative Roadmap for Indian Country on the Leadership Committee. And so we're very excited to have her join us, and I'll talk a little bit more about that roadmap later. Dr. Hartwig was also the former medical director of Nimipu Health, tribal health clinic for the Nez Perce tribe. And we also have Dr. Jordan Angun Lewis. And Dr. Lewis is the Director of Research, Center for One Health Research, and research professor at University of Alaska Fairbanks College of Indigenous Studies. So I'm so excited to have all of you join us. We're going to start with Michelle Archuleta, who can give us sort of a landscape of what IHS has been doing in this space in terms of providing programs and resources to improve care for people living with dementia, and certainly talking about some specific initiatives such as the CHR mini-cog screening pilot. So with that, Michelle, I will turn it over to you. And you are muted. Let's see.
There we go.
There we go.
Okay. Oh, sorry. Thank you, Edie. It's such a pleasure to be here and to participate in today's panel. I am going to take, just a few moments out of the presentation to, again, talk to you about what IHS is doing at a national level. I'm super excited to share about our national Alzheimer's program, our collaboration with the CHR program that, as Edie mentioned, that is my responsibility addressing community health worker workforce development and training. So with that, also just to let you know, I am an enrolled member of the tribal Lone Pine Paiute Shoshone Reservation. We're a small little tribe right there below Mount Whitney on the Eastern Sierra Nevada mountain range. So again, this is my intro slide, and When we talk about the Indian Health Service, we're really talking about a very large health system. It's the 17th largest in the United States. And, our health system provides primary care and prevention. We have area of about 2.8 million American Indian, Alaska Native people that receive care, treatment, and services from three very different health service delivery systems. We're 574 federally recognized tribes that are really reaching across the 37 states, but you can see we're categorized or identified according to these areas. So the California area, the Tucson area, you can see the Nashville area is quite large. It's the eastern, I would say, side of the United States, but you can kind of see this just to give you an idea about the Indian Health Service. And I mentioned we're three very different, unique healthcare delivery systems that make up this Indian Health Service. And I'm going to work from the right side. So we're comprised of an urban program, health system delivery component. We have 41 urban programs across the United States in large metropolitan areas. And they're about 1/3, 1.3% of the IHS budget. And then we have in the middle this large tribally operated component. And that is more than half of the IHS budget that helps support tribal healthcare systems. And then we have this IHS federal component. And so this is the direct service delivery piece from a federal hospital system component. So there are three separate systems here. And then I'm just gonna let you kind of see this. I'm not gonna really go over it because you'll have these slides if you'd like. But it ranges over 600 plus hospitals, but you can see the services that are delivered. And so we're very excited to really kind of move into this Alzheimer's and dementia piece. With my particular program, the community health representatives, we're more in this community health component right here. So IHS has a fabulous, very, very trend-setting Alzheimer's program that has really come into its own, starting back in I would say 21, 22, and so on. And you're going to see a lot of these programs that IHS, and they have a wonderful team that really has, I would say, set the vision for, I would say, high quality, innovative, a lot of best practices, promising practices, from tribes in terms of meeting the demands of Alzheimer's and dementia. And so this is one of their, I would say, taglines that you see here. And so I'm going to keep moving forward. And here's this fabulous team. We have our own community health branch chief, Nicole Cartier, and Jolie Crowder, Dr. Crowder, who really has, really pushed everyone, I would say, to, think broadly about dementia, partnerships, what we can do with prevention, screening, that type of thing. And so her colleagues, Valerie Jones, does a lot of the data piece. Dr. Fink, very instrumental in providing that elder health consultant knowledge around care. He really is really set the tone for Alzheimer's and dementia before this team really kind of got going. And then a couple of new people, Dr. Bellatoni from the Phoenix Indian Health Center, and Jamie Olson, who works at the headquarters level, providing tremendous program support. So IHS with this Alzheimer's program, it's really kind of framed around what you see here in these large, I would say, bucket or circle areas. And so this all came out of tribal consultation and urban confer. So it really was a lot of input from tribes addressing what they saw as a need around dementia. And so that was brought into the team, and they started to really craft out these opportunities to provide grants and program awards to tribes to create these models of care. And so sometimes these models of care are 1 year, 2 year, sometimes they're renewed. There's a wonderful outreach and dementia component around communications and the program support piece that really is now kind of gathering all of what you are going to see with these models of care practices around evaluation. And then, I mean, what's really, really exciting for all of the IHS workforce is this commitment to building capacity and education. And so this is around Alzheimer's and dementia education and training for nursing, for providers, community health representatives, pharmacy, health educators. And so we're super excited, to be really kind of in partnership and working hand in hand with our new contractor. And you're going to hear a lot about them on this call. And then this building out of caregiver support. So you can see these are the large component areas. And then right there, you can see there's funding that's attached to what you see here in the terms of appropriations of 5 million. And so we think that's, not enough, but it's good enough to like help us, move forward. So in a lot of these areas. So this one slide right here is really kind of where you see this National Alzheimer's program as they've really took off in 2021. And, it was this tribal consultation, as I said. This is where they received their first appropriation with funding. And then program people were hired on. They developed these pilots around Jerry Scholars, developing an MOU with the Alzheimer's Association. And they really started to build out each year. And you can see as time has moved on in a short amount of time, it's really just kind of exploded. And so you will have this opportunity to learn more as you visit the website of Alzheimer's. And we have those links for you. But, in 2023, they really, really just kind of took off with lots of fellowships, pilots. And then this is where also Dr. Crowder and we really started to collaborate in 2023, thinking about how we could bring in the CHR workforce to help support dementia. And so we're going to focus a little bit more on what we have done with a pilot called the CHR mini-cog screening pilot. But you can also see in 2024, I mean, they're just growing. And so there is I would say, a big opportunity in meeting this need. And so again, as I move into the CHR program, you're going to hear a little bit more about this pilot and where we're going into 2025. So I like this slide just to let you see, from, this United States, where these program awards, where these grants are based. And you can see also the year that they were funded, and maybe they were refunded. And so, take a look at some of those tribes that you're seeing, and very super exciting here. So now I'm going to move into our National Indian Health Service Community Health Representative Program. And because this is really, I would say, um, very collaborative. We are training, we're building capacity in that space of dementia, really around early detection. And so here is our own CHR. I would say the first two people, so it's myself and then I would say amazing Pamela Aguilar. She's one of the contractors that we have that really is, we're the ones behind this national CHR program. And then when we talk about the CHR MiniCog pilot team, that's where we have Dr. Crowder and Jamie coming on board. So, here we are. And this is just showing you our CHR workforce is, it's the largest tribally contracted and compacted program. And what I mean by that is it's, it's run, um, it's run directly through tribal leadership, tribal governance. And so that is, I would say, where we strive to move, I would say, programs and I would say these opportunities where, because that fits in with Indian self-determination. And so we're really a model program that represents, this compacting component. And I would just say one of the things that I really like you to think about is our CHR workforce is very large. It's very diverse, and we have up to 1,200 CHRs across the United States working in tribal communities. And you can find out more about this at our webpage there in the link. One of the main, I would say, reasons for the impact that we have as CHRs is where we're situated. So we're not a clinical, within the healthcare system, within the four walls. We're outside, we're out in the community, and we're in the home. And so much of our work is delivered impacting what we call the social drivers of health. And you can see this here on the right-hand side. And what I did is I just kind of laid out what we do as a CHR program in terms of our services. So anytime we're doing a home visit or outreach, providing access to care, moving in this care coordination space, we're really looking at those 40% of the socioeconomic factors. And you can see, as we kind of go through these home environmental checks, that's really helping, I would say, helping to support this physical environment component that impacts our health. And then the types of community education. And with dementia, we are so pleased to have this partnership with the Oklahoma Dementia Care Network, where, as part of our dementia training, we have we have that knowledge to help around, I would say, this health education piece. So, I mean, you can kind of get a piece or like a lens of really how CHRs really help support and impact these social drivers of health. Well, so when we talk about dementia with the Community Health Representative Program, we really kind of moved into this space back in 2023. And so this really was kind of formed around two key priority areas with our national CHR strategic plan. One is around forming partnerships. So we have, within house, one with the Alzheimer's program, and then this Oklahoma Dementia Care Network. And then the other priority area is workforce strengthening. And this is where the dementia training really comes into play here. In 2024, we implemented our first pilot, which was our MiniCog screening pilot. And that was really around a strong communications component. I would say our partnership with the Oklahoma network. And now in 2025, we're moving into our second pilot. So we have this as a new cohort. And we're also exploring and building out what it would look like for a CHR program around risk reduction with dementia and caregiver coaching. So here it is, our first year, which was year one. We had, some primary aims, and we really wanted to test out the use of this mini-cog brief cognitive screening tool. And you'll see a little bit more about that in the next slide. But we wanted to find out how CHRs responded to using this mini-cog tool. Did they feel like it was something that was just something that, fit within their scope of work? And then we really also secondarily wanted to keep raising awareness of dementia. And we did this through a lot of social media. So you can see this is one of our social media posts that we have on the right-hand side. And then part of the pilot was about peer-to-peer learning. And we collected data where we looked at the number of screenings delivered. We looked at what was considered a positive screen or a negative screen. And we looked at clinical referrals in this. And I'm not really going over much of that at all. That's in a report that we're having finalized. But we had 6 CHR programs that went through this over 6 months. And this is just one slide that really talks about the mini-cog. Very simple, pretty easy to administer. But it does take practice. It takes practice to kind of get that comfortable, I would say, feel. And so, we're still doing that, but we do like this mini-cog assessment tool. So yes, we came away from that first pilot that CHRs absolutely are and can implement this cognitive screening component using the mini-cog. And so what was really exciting that we consider a big success is because one of our programs, which was the Santo Domingo CHR program, they were in our first pilot. And after that first pilot, they went in and applied for one of the larger Alzheimer's grants, as a program award, and they were funded. And so you can kind of see right here, they're moving beyond just screening, and they're really now have brought in clinical colleagues, public health nurses, providers. So, that is just taking off, and it's very new. But we see that as a real plus. And then I just mentioned briefly in the presentation, we have a second pilot. Well, what is super exciting about this, and this is going to happen in January in 2025, 20 programs have applied for this, whereas our first program pilot, we only had 6. So we think that is, I'm going to use the word exciting again. And then this is a last slide. If you want to learn more about our CHR program, our mini-cog pilot with the Alzheimer's program, or if you want to learn more about the Alzheimer's program on its own, feel free to go ahead and click on each of these sites. And then I just left this here. I am not going to go through it, but there's because this is really only 10 minutes and I probably have taken up too much time, but you have additional information and resources. And so I'm just going to let you see more of what we really feel is also important, that you are absolutely able to reach out, and we're happy to have a conversation. So with that, I am going to
Yeah.
stop. It's all yours, Edie.
Thank you, Michelle. I know I am so excited that there's so much information to share. So we're going to try and get through our next 3 presenters in the short amount of time. So we will answer some questions at the end. I know there were already a couple questions, so we'll share those at the very end. But let me introduce Dr. Ducour to talk a little bit more about locally, particularly, I guess, in California, of what's happening there. Dr. Ducour?
Thank you, Edie. Can you share my slides, please? I'm so glad to be here with you all today and honored to be a panelist with this. My name is Susan Ducor, and I'm the area nurse consultant. And as Edie has said, I wear many hats, but I'm also the area community health representative, area office consultant. So that's the space that I work closely with Michelle in, and wear some other hats as well. But I've been with the California area office since 2001, and I've worked closely with a lot of the folks on the IHS elder health team over the years with fall prevention and other aging opportunities and things like that. So I'm just delighted to be able to offer this in this space today. I wanted to share a little bit of our partnerships at the California area, our collaborations and partnerships. Next, please. And talk about the frontline efforts to address Alzheimer's and dementia in tribal communities. So some of the information that I have on slides, I think that Michelle has already covered, and I'm very grateful for that. She did a great job and brought it all together. So I just wanted to tell you, I come from the California Area Indian Health Service, and it's the area office is one of the 12 administrative offices within IHS, and it provides a healthcare delivery system to the state of California for American Indian Alaska Natives. And it turns out that the California is home to the largest population of American Indian Alaska Natives in the country. The California area office, where I work in public health, works to ensure that we have high quality health services that are available to Indian people in California, and particularly the Office of Public Health professional staff, clinical consultants such as myself and others provide training and technical assistance in addition to performing other federal functions. Next, please. So this will be a little bit redundant, but specific to the California area, most of our services are tribally operated healthcare services. Tribal facilities are operated under the authority of the Indian Self-Determination and Education Assistance Act, Public Law 93-638 as amended, Titles 1 and 5. Of the programs in the California area that provide ambulatory healthcare services, there are 34 tribally operated programs that operate 66 ambulatory care clinics, and the various forms of accreditation. One is Joint Commission, and 14 of these are accredited through the AAAHC, or the Accreditation Association of Ambulatory Healthcare. There are also 10 urban programs. We have a huge population that live in the urban areas as well as in the rural, but these 10 urban programs range from community health to comprehensive primary health care services. And I'm a project officer on 2 of those, so I'm very much aware of the need for resources for all of our programs. I'm also a project officer, federal project officer on several of the tribally operated ambulatory care programs, or on the, excuse me, yes. Next, please. And just a little bit about us. We have 140 or 104 federally recognized tribes, 88,887 American Indian Alaska Natives that reside on or near reservations. And then you can see the 2010 census just kind of shows that we have some users in contract health delivery areas called CHISDAs. And we also have 195,000 plus that are potential users, but they're not living in an area that that will allow for them to have the contract health service delivery or services. So, and according to the 2020 census, you can see the American Indian Alaska Native population in California was 631,000 plus. Next, please. And then just a little bit about the efforts that we're engaging in at the, I should go back to that. This slide is, I borrowed it from other presentations. You know, it talks about our Native American culture and how how much we have high esteem for our elders, and we're more likely to take care of our elders at home as they age in place. And this may, in fact, create stress for caregivers. And that's where the CHRs and the public health nurses, outreach nurses, and others come in. As many as 1 in 3 Native American elders will develop Alzheimer's or some other form of dementia over the course of their lifetime. And between 2020 and 2030, we know the number of American Indian Alaskan Natives is expanding, and individuals age 65 and older living with dementia is projected to increase fourfold. So the numbers are staggering. And we also know that 61% of Native Americans say that affordability of healthcare is a barrier. And then lastly, bullet on the slide is, the vast majority, about 92% of Native Americans say that it's important to have culturally appropriate care and care by caregivers who provide their ethnic or racial background. And we only have 49% of Native Americans say they have access to culturally competent providers. So that's another area where we have to work. Next. And area and IHS partnerships, collaboration, and outreach activities. We have partnered most recently in 2024. I'm sure we had some presentations earlier than that, but I'm just going to focus on 2024. In May, we had the wonderful opportunity of having the Alzheimer's Association, Cheryl Brunk, provide a presentation at our area program directors meeting that was held in conjunction with our May 2024 California Best Practices Conference. And then the Alzheimer's Association, as a result of that, partnered with the area office to offer a 1-hour virtual dementia care aware cognitive health assessment training for providers in the California area. And that occurred on August 1st. And then in 2025, I said 2025, I was incorrect. My slide's wrong. It's 2024. We had our California Area Best Practices Conference, and we're very fortunate to have Dr. Fink and his elder health care team, as well as 2 of the recipients of funding, Northern Valley Indian Health and Indian Health Council, both of whom received the IHS funding to support their efforts in building capacity and developing models in Indian country within their communities. Both of those programs, and then Northern Valley Indian Health, as the last bullet, also was a recipient of the mini-COG funding and pilot that Michelle talked about earlier. And so we can move on to the next slide. Thank you. And IHS grants and program awards, as I've mentioned, we had 2 recipients in the California area, the Indian Health Council and Northern Valley Indian Health. They both received the initial 2-year funding in 2022, and then again were awarded 3 additional years in 2024, and I believe that started in September of this year. So they're moving forward and hoping to build further developed models of care and build capacity for sustaining their program efforts. Move forward, please. Next. And then each of these 3-year funded awards, they were targeted towards programs with established efforts to address dementia, and they did have to apply for these funding awards. And 3 years additional funding support is being provided for both of those California sites that I've mentioned, and further development of their models of care and sustainability will be their targets. Next. And capacity building and model development, I'm just going to talk briefly about some of the things that Northern Valley and Indian Health Council have done with the funding that they received. Northern Valley provides comprehensive and integrated medical, dental, and behavioral health, women's health care, nutrition, community health, and outreach services to over 6,500 American Indians and Alaska Natives who reside in the Northern Valley Indian Health 5-county service area. And they have several clinics. They primarily work out of Chico and Woodland, and then I believe they have one other administrative site. And then we next have Project Outcomes. They increased their early recognition and referral of individuals in cognitive impairment, and implemented in practice annual wellness visits for recognition, leading to the assessment and care planning. They incorporated caregiver coaching and support and individualized health plans, integrating caregivers. Next, please. And then at Indian Health Council, they're a AAAHC accredited 501c3 tribal healthcare organization, and they have full service ambulatory care clinic as well. And they have Indian Health Council has integrated care concept, and it represents medical, dental, behavioral health, and pharmacy. And the consortium of 9 tribes and associated Native American populations, and it's located in San Diego's North Country Valley Center, and they have 2 locations. Their project outcomes, they use the annual wellness visits as well to increase the early diagnosis. And then they provided training and frontline staff in cognitive screening and recognition, and implemented use of interdisciplinary assessment and care planning using Medicare codes. And they also formalized referral networks with tribal and other organizations providing services in the area. They very much focused on patient-centered care and access to specialized services and caregiver support using public health nurses and CHRs, along with links to community support services. And although they weren't a recipient of the MiniCog grant, to my awareness, they have incorporated MiniCog in their program efforts.
Thank
for
you,
the
Dr.
MiniCog screening.
Ducour.
Next, please.
Dr. Ducour, I'm going to have to start to switch gears. We've got
That's fine.
limited time, but thank you so
Thank you.
much.
I think
Yeah.
that was it, and I really appreciate it. Thank you.
Perfect. As you can see, there's just a wealth of great work happening locally and nationally from Indian Health Service. Our next presenter is Dr. Jordan Lewis, who will talk a little bit more about the work that's happening that he's doing in particular, but also just some new developments to engage our Alaska Native population. Dr. Lewis, thank you.
Great. Thank you so much for this opportunity to share what we're doing in Alaska. So as mentioned earlier in the introduction, I'm Jordan Lewis. My family are Aleut and Sugpiaq from the native village of Naknek in Southwest Alaska in Bristol Bay. And I'm currently the Director of Research for our Center for One Health Research. And this presentation is kind of give you some insight on some of the wonderful things happening in Alaska. So just some brief statistics. As you can see, just they're as everywhere, right across Indian country and the world, the rates of people with dementia. This is Alaska Native and just non-native populations, but it's increasing with, projected 11,000 people across the state. Alaska is large, but we have a small population. I think it's about 800,000 plus people. And you can see it's one of the top 20 causes of death for Alaska. And so with this, there are concerns, and we have several excellent programs being developed, services being offered. And within the tribal health system, we have really innovative and exciting projects and programs happening. But of course, as everywhere, as we work with the state of Alaska, I've been involved in this work for a few years. The development of the Alaska Dementia Action Collaborative kind of was developed in response to updating the roadmap for dementia in Alaska, and kind of thinking about what are things we can do and how can we work together more collaboratively across the state. And as a result of the Action Collaborative, we came out with this call for action, a new 10-year map to address Alzheimer's disease and related dementias, native and non-native, in response to some of these larger gaps we're noticing, lack of education and training across the continuum of healthcare providers, from our community health aides to our MDs, and our VP, the village protection safety officers, as well as within our, our training programs at the academic institutions, the university system. we have this, lack of awareness. We have students who are interested in wanting to know more, whether it's because they're taking care of relatives or family members with dementia or hear about it. But we also are noticing, Alaska is very remote, very rural. And so thinking innovatively about how do we bring more training opportunities to these rural locations. And I would also argue we need more of these training programs that are accessible in urban locations, and thinking about, not everyone has access to the internet or has time to go to Anchorage or Fairbanks to attend a training. And so what are some innovative things we can develop that are accessible, that are offline, and really provide some very tangible, concrete things that people can do. For example, just learning the basics of transferring someone from a wheelchair to their bed. And so looking at what those look like and making sure they're culturally sensitive and culturally safe as well. So I want to highlight just some of, the exciting things that are happening across the state. I want to thank the colleagues I reached out to kind of help think about, compile a list of things, because there are some wonderful things happening. We don't always hear about them, but there are, a few of our communities and a few of our agencies got the BOLD funding. So Alaska's Dementia Education and Prevention Program received the BOLD grant. And really they're focusing that funding on establishing a public health center of excellence for dementia, supporting public health departments to develop more infrastructure and services in this area, as well as increasing data analysis and reporting related to dementia, not only across the state, but we're also, their South Central Foundation and our tribal health system are also working on really increasing and finding ways to collect more of this data so we have a better picture of what's happening. On the other side of things, more the service providers, the client services, Fairbanks Denali Center, a few of other healthcare facilities in Alaska have really been instrumental in developing more culturally safe, innovative programs, such as providing nutritional foods in the care facilities, thinking about innovative ways to serve families and their relatives with dementia, and kind of leading this movement towards culturally safe care. And how do we engage our families and our communities in efforts to remove that stigma that is still around with dementia and the fear around growing older. Nutritional foods has been a big movement in Indian country, not only in our care facilities, but the hospital in Anchorage, has nutritional foods as well, and kind of looking at how that impacts the quality of care and services we provide, not only to people with dementia, but their families and just individuals who are using those services. With regard to the Indian Health Service Dementia Grant, which we've had a great overview of the previous presenters, the Norton Sound Health Corporation have received this, and they have their second cycle of funding, and they're working on hiring staff to coordinate patient assessments, work on the referral system, and developing other team efforts. They're also really working on establishing more collaboration with the regional, tribal, and community services, thinking about sharing and making more awareness of the best practices with the IHS programs, not only with the Norton Sound Health Corporation, but across the Alaska Native Tribal Health Consortium, which is our IHS system that serves the entire state. And they're also focusing on exploring other funding options, including a pilot program for respite care. So that's one example. Another IHS dementia grant recipient is the Kenaitze tribe. They've been using this funding to develop and introduce a comprehensive dementia care program, really combining the different types of care from various providers, establishing and developing careful supervision, and having this commitment to sharing insights with others. I think Alaska has done really good in sharing what we've learned, whether it's what went well or what didn't go well, and kind of building upon what other people are learning from their experiences to improve the services they're offering. Other programs that have been really exciting and doing wonderful work, the Aleutian Pribilof Islands Association has also been doing great work with their dementia services. They've offered the virtual dementia tour across the region and different communities. This is a great way to increase education and awareness. And this region is very remote. And so I think it's great work that they're bringing that out to these communities who may not have access to to the services that may be available somewhere else. And then the Manilik Long-Term Care Facility was shared with me that they have shadow boxes outside each resident's room that consist of things that are important to them, whether it's pictures or things that they can put in there. And it's a way for the residents to feel at home, but also know where their room is. And so it's another way of really person-centered care and making them feel more at home. And then to kind of end, shifting gears a little bit away from Alaska, but more across the Indian Health Service ITU system, the new TRIAD project, which stands for Training and Resources for the IHS on Alzheimer's and Dementia. This is a large multi-site project with an incredible team of people across different areas, from MDs and healthcare providers, people at IHS, and myself. I work with a team, is the co-director of TRIAD. But the goal of TRIAD is to improve recognition, diagnosis, and management of dementia, to improve care and outcomes for American Indian and Alaska Native people living with dementia, as well as their caregivers. And so how we're accomplishing this really big project, which is really exciting, is, we're developing culturally informed training materials and education. We're looking at kind of doing an eco map of evidence-based interventions to see what's out there, what could be used, what's applicable to our communities, and then looking also at the best practices and kind of figuring out what may work or not work in our communities across the ITU system. So it's not just, we're working with Indian Health Service, but also tribal organizations and Urban Indian Health Institute. So the primary purpose of TRIAD is to improve ITU staff knowledge, attitudes, and behaviors related to dementia diagnosis and management. And this is done by creating discipline-specific, competency-based training opportunities. And the other two primary purposes, the second one is to establish new and manage existing pilot training programs, specifically focused on dementia training. And then the third one is to identify, train, and support clinical and community dementia care champions in the ITU system. And so this project started this past summer, and it's really exciting to work with an incredible team of people who are committed to this work. And that is, thank you.
Perfect. Thank you, Dr. Lewis. We don't often hear enough about all the good work that's happening in Alaska, so I appreciate all the specific examples and to know that there are some great developments happening there, specifically with some of the BOLD grants and whatnot. So thank you. Well, we want to also hear from Dr. Hartwig to share a little bit more. What are you hearing and seeing working directly with patients and families? So I will turn it over to you.
Thank you, Edie. And I also want to echo the invite and ability to present some of our program, the memory care program. I know we have a couple of our staff members on. I am no longer at Nimipu Health, but certainly want the program to succeed. Next slide, please. So just a little bit about the Nimipu Nation, or the Nez Perce tribe. We were in the first cohort for the IHS funding, and we were the only rural facility that received funds to develop a program. The Nimipu Nation headquarters is located in Lapwai, Idaho, but our traditional and custom hunting and gathering lands include southeastern Washington, northeastern Oregon, Idaho, and parts of Montana. Nimipu Health is the compacted 638 clinic for the Nimipu Nation that received the IHS Dementia Model of Care funds to develop a memory care program for our community in 2022, and we were refunded in 2024. The logo on the right is what all of our memory care program materials have are included. One of our, these are two of the elders from our community, and we don't have word in our language in Nimiputimpt for dementia. And so we're really trying to approach the development of our program in a cultural nature. And this beautiful logo was created by a tribal member to depict that importance of culture at the center of our of the program. Next slide, please. So I was asked to discuss kind of direct care observations in the program. As Edie mentioned, I contributed to the Alzheimer's Association and the CDC's Healthy Brain Initiative roadmap for Indian Country on the leadership team. Gaining knowledge and education in realm of care as a family physician can be approached sometimes with hesitation, because primary care has to add yet another scope of care to the already full plate that we have. But I think the programs that IHS and support and resources that so many programs have been developed to support care, dementia care specifically, have been extremely helpful. Some of the observations that have been made with respect to direct care include trust. So we received the CHR funding and training for the pilot project, and had some hesitation in our community. And new programs generally in Indian Country with community involvement they're challenging, because our communities have felt for so long, many generations, that we're kind of guinea pigs for care. Much of our team has kind of shifted focus for us to just be in the community. With the Circle of Elders, with the Senior Advisory Committee, we've conducted community health projects like art, pottery projects. We've had Alzheimer's awareness walks, really trying to build a relationship with our community members in really and foundationally building trust, so that the information that we're passing out within the community can be received. The other component that really was paramount for our program was that we selected members from our community to lead the program. Our program coordinator had previously worked with several elder programs prior to her capacity in joining the Nimipu Health team as the program coordinator. And and those relationships are really important for carrying any information forward. The second observation with respect to direct patient care has been staff and education. We were fortunate to find community members who are dedicated to elder care with prior experience, as I just mentioned, and educating our staff and community was daunting, but our collaborations that we have generated in our region have been extremely helpful. I think that it often or sometimes can feel like we aren't progressing as quickly as anybody would like, but the education and confidence that we're gaining in that knowledge, kind of being a champion, is really important for us to hold on to, and that's progressing very well. The collaborators, and many that have been mentioned today in previous presentations, we had external partnerships, and this can be found on the IHS website, but we have had the Alzheimer's Association, who assisted with training to implement caregiver support groups. And you'll learn as you develop the program how integral caregiver support groups are, and really with dementia not having definitive treatments to necessarily slow or hasten the progression of the disease, supporting the caregivers to be able to provide the care and services that we need to keep our elders at home is extremely important. Community action partnerships provide caregiver support groups. We had University of Idaho Extension and Dementia and Friends come give Dementia Friend Champion training for the memory care staff. And as mentioned earlier, and I'm not sure if I emphasized this enough, we chose to not name our program Dementia because, as I mentioned, we don't have a word in our language for dementia. So memory care is what we chose, also to try to reduce the stigma associated with dementia. So those kind of more sensitive approaches are important to factor in when you're considering trying to avoid labels that Western medicine likes to apply to various conditions. And those labels are important clinically to communicate, but oftentimes patients are not welcoming of those labels. The Northwest Portland Area Indian Health Board has echo sessions that have been participated in, and then I presented at the 2024 Tribal Brain Health and Dementia Summit with that bold funding through the Northwest Portland Area Indian Health Board, specifically around trauma and historical trauma and its impacts on dementia at the latter stages, more advanced stages, specifically with behavior. Also collaborated with several tribes, our local school district. The Idaho State University hosted the Hispanic American Indian Healthcare Conference, which our memory care coordinator presented at, and then we had art therapy for caregivers and families. Our state Department of Health and Welfare, as mentioned earlier, the Healthy Brain Roadmap for Indian Country with the CDC and the Alzheimer's Association. And one of the really important components for internal partnerships are our social services, our adult protection services, veterans program, our senior program, our language program, our horse program. We're trying to develop equine therapy for both the elders that are impacted by dementia or cognitive decline, as well as the caregivers, because the horse was very important in our culture and many of the upbringing of our tribal members. The comprehensive care and community health and our SDPI, Special Diabetes Program for Indians program, our communications program within the clinic tries to get out as many educational materials as we can. Our PRC, Purchase Referred Care departments, assisting to get our members signed up for alternative resources so that we can get some payment and create some sustainability. For the 2024 award, we have a collaboration with Splain Consulting, who has worked in with IHS, contract with IHS for a number of years to really help us with that billing component so that we can create a sustainable program. The grant funds are really important in helping us to enter into the realm of dementia care, but we have a responsibility to create some sustainability for the program so that we can continue to provide the care that our people need.
Thank you so much, Dr. Hartwig. We are out of time, unfortunately, so I appreciate everything you shared, and Nimipu Health Center and all the great work that they are doing as well. So thank you. Well, I do want to mention before we close a little bit about the Alzheimer's Association and what we're doing. Certainly, you saw the growth in the appropriations, federal appropriations to IHS. And just have to say that the Alzheimer's Association, we are one of the largest advocates on behalf of individuals living with Alzheimer's and dementia. And we certainly advocated for federal dollars to support American Indians and Alaska Natives in Alzheimer's and dementia. So very exciting to see what is happening, and certainly with Jordan's work as well. I will share that we have a new Healthy Brain Initiative roadmap for American Indian and Alaska Native peoples that will be coming out. And so I'm going to share in the chat with you all. If you would like more information about that, please go to this website, and we are so excited for that to be released. This is a public health strategy approach to help communities start that conversation of how do we locally address Alzheimer's and dementia. Additionally, the Alzheimer's Association, we have 75 chapters across the country. And so if you're looking to see how can I get more information locally for my community about Alzheimer's and dementia, education or support groups, we have a helpline, a 1-800 number, and also a website, alz.org. But we also have a specific page that is focused on Native Americans as well. So hope to get that to you while I am talking. But one of the things most important is just to know that we have chapters across the country, and I hope that you will find that useful. So we did have one question. I think for those who might be wanting to stay on, I would love to ask this because I think it is an important question, which was perhaps to Michelle, if there have been any concerns about the mini-cog not being culturally safe or acceptable in Native communities. I wonder if you could answer that briefly.
You know, we have not experienced that. It seemed to be received. The only thing I think was maybe, the practice, people, CHRs feeling, that comfort level. But again, anything new just takes time.
Mm-hmm.
So I'll
sense.
answer it that way.
Well, oh, Dr. Hardwick?
Yeah, I'll just mention that hesitancy with the newness, as Michelle mentioned, but there was also a hesitancy, I think, surrounding the stigma of having that label of dementia in the mini-cog. We had several elders that refused to participate in the mini-cog screening, I think because of some concern about that.
I would echo that, yes. And I think that's something new that, as Dr. Hartwig brought forward, we're going to have to kind of figure that out, this stigma piece around dementia.
Yes, and someone else has brought up that there currently is no culturally validated evidence-based tool to use with the population. Certainly, yes. Dr. Ducour, you had your hand raised.
I was just going to add to that one of the findings from one of our programs was that there was cultural stigma, but it was around the diagnosis. It wasn't around the screening or the use of that mini-cog screening tool.
I see. Okay. Well, perhaps just one more question, if that's possible. We have one here. Does the lack of a word for Alzheimer's inhibit the ability to receive adequate or appropriate levels of funding or coverage for patients, clinical care in particular, and then also research? I wonder if Dr. Lewis or Dr. Hardwick, anyone here would like to answer that.
I think that the IHS dementia team has done a great job. I know that we had received CMS codes that we could build into templates that were helpful. I think that there's often a translation between the care that's provided and the information that's given to the patient, not that it's not true or appropriate, but that we are mindful about what we're relaying to them. We certainly have to code appropriately if they have a dementia or Alzheimer's diagnosis or some condition with cognition, but how we relay that to the patient is extremely important for them to understand and not be harmed by that.
Mm-hmm. Dr. Lewis?
Yeah, I would just add that we haven't had any concerns. I think is people are learning more about it and having more awareness of, whether it's they use the word memory problems or Alzheimer's. I would say the language that's used may vary by generation. Like younger people are more familiar with Western ideas of Alzheimer's or dementia, but even our older adults may have some familiarity with it. Yeah, it hasn't been a concern with in regards to research.
Well, we will end with that. Thank you, everyone. Thank you to our panelists. Appreciate all the expertise that you all brought and look forward to learning more about your progress. Thank you all for participating. We will send out the recording back to you, and please feel free to share it with others. Thank you. Awesome. Take care. Bye.